Welcome, everybody, to our, I believe, fourth webinar this month. And this is on neuropalliative care. We are fortunate today to have two people with us. We have Dr. Jennifer Corcoran. She is a senior instructor of neurology at the University of Rochester and a movement disorders specialist in the neuropalliative care unit. And we have Bernadette Skobjak, who is a former caregiver and quite a champion of neuropalliative care. So thank you both for joining us. And let me start with you, Jennifer, just by the question that I'm sure you hear all the time. As you know, people are often confused about the difference between palliative care and hospice care. So I'd like to start by having you explain what palliative care is and how the two differ from each other.
Yes, I do get that question quite a bit. Palliative care is a philosophy of care, I would say, that and a specialty of medical care that aims to improve quality of life for anyone living with a serious illness. So this can happen or be necessary at any stage of a serious illness. For example, I see a lot of people in my practice with Parkinson's disease, and I see people with early disease, middle disease, and late stage disease all the time. This is care that is often interdisciplinary, multidisciplinary. I work on a team with chaplains, social work, nursing, etc. And we really aim to improve quality of life for anyone living with serious illness. And this involves, treatment of medical symptoms. It can be support for some of the psychosocial challenges that come with a serious illness, financial issues, navigating systems. For care partners and families, we really try to provide extra care partner support because they're such an important part of the team. And as I'm sure Bernadette is going to talk about, there can be really unique challenges to caregiving in a serious illness. And I'm a neurologist. In a neurologic illness, there are unique challenges. So it's quality of life focused care throughout the course of disease. Hospice care is I would say almost like a very specific type of palliative care, which is care that is purely focused on comfort for people who are coming to the end of their lives and who specifically have an expected prognosis or life expectancy of 6 months or less. So while palliative care includes and encompasses hospice, and I am sometimes a hospice doctor for my patients, palliative care is much broader than that.
So I think another question that comes to mind is, are there any limitations when you are involved with palliative care? Are there any limitations on the kinds of treatments you can receive?
No, not at all. So like I will see people for consultation include, for help with medical decision making sometimes if they're struggling with a big medical decision. But it's always on the table. Like, do you want intervention? Do you not? I aim to be thoughtful about it. Palliative care can happen at the same time as curative treatments. Like, for example, someone who's getting chemotherapy or surgery or radiation for like a cancer can certainly get palliative care for support while they're doing all of that. We can also help with decision making about whether someone wants to do that, but certainly seeing palliative care for support is not inconsistent and does not contradict people getting other types of treatments or being in clinical trials or getting surgeries or doing those other types of medical treatments.
So really no limitations when you're involved with palliative care, other than what you and your doctor decide on.
Yeah, it's really based on needs, I would say. Like if there are palliative care needs, it's worth seeing a palliative care specialist or if they can't be addressed by a regular medical team.
Great. So that leads me to my next question, which is, if someone is diagnosed with a chronic illness, should they consider involving palliative care? And when would you suggest is the best time to do that?
I think this depends a lot on the illness in question. Certainly, if there's a life-limiting illness, I think, earlier is better than later, such as in, like I said, I see a lot of people with Parkinson's disease or dementia or other neurologic illnesses, many of which are life-limiting. And I think earlier is better than later. Sometimes, like my involvement early, since I see people for palliative consultation, sometimes my involvement early on might be sort of sporadic as needs come up, and then I might take over more of the care or be more involved later on as palliative needs accumulate. Other reasons to see reasons to see palliative care might be difficult to control symptoms like pain or nausea or fatigue or some of these things that come up. There might be needs for care partner or other psychosocial supports. There might be needs for talking about sort of like roadmap ahead and what does this disease look like in the future? How might things evolve? Advanced care planning, talking about goals of care. Those would all be some things that could trigger the need to see palliative care. And some of those things, depending on who you're seeing for, your chronic disease treatment, some of those things like certainly don't necessarily need to see a specialist every time. Plenty of people can get some of these things met by, their oncologist, their cardiologist, their neurologist, their primary care. But if there's challenges getting those things done, that is when a referral to palliative care might be helpful.
Great, thank you. Bernadette, can you talk to us a little about your experience with palliative care as the caregiver for your husband?
Yes, I would love to. First of all, my husband died of Parkinson's 5 years ago, and we we struggled through his journey with Parkinson's. And one day we were at a meeting with his counselor, and I can't even remember how it came about, but I was very emotional, and I broke down. I was crying. I was sobbing, and I remember telling the counselor, I don't know if I can do this one more day. The caregiving had become extremely hard, and I was experiencing a lot of sadness. I was crying a lot. I screamed sometimes, and so I was expressing this to the counselor. And the counselor said, she said, I think you and Fred could benefit from palliative care. Well, at that moment, we had no idea what palliative care was. We didn't know anything about it. And so we didn't even understand what that might entail. But nevertheless, we agreed to go. When we got in the car after that meeting with the counselor, I remember Fred and I looking at each other and saying, what is another specialist going to do for us? But we went to the first meeting, and boy, were we glad we did. So our first meeting with our palliative care doctor was about a year before Fred died. At the time we had that appointment, we had no idea that he might die within a year. We thought he might live several years after that. Now, why were we glad we went to that first appointment? So we meet our palliative care doctor, and he asks Fred and me, he says, what is your plan? Well, as a caregiver, what did I say? I said, oh, the plan is I'm going to take care of Fred as long as I can. And then he asked Fred, well, have you completed your MOST form? MOST is medical orders for life-sustaining treatment. And Fred said, well, we have the form. It's been on my desk for over a year. We haven't been able to deal with it, mostly because we didn't even understand all the questions on it. So our palliative care doctor kind of reached up to his shelf, and he pulled a MOST form off, and he said to Fred, well, we're going to talk about each one of those right now. He said, we'll walk through it, and you'll make some decisions. Well, as we did that, we were both so glad that he took the time to do that with us, because Fred was very worried about some of those life-sustaining treatments and wanted to be very clear in what he wanted and did not want. And it was important for me as a caregiver and as his wife to understand what his thinking was about these various life-sustaining treatments. So just that experience, that beginning experience, was so helpful to us. The palliative care doctor went on to ask Fred, and this goes to something that Jen talked about, asked Fred, well, which of your symptoms, are the most upsetting to you, the most troublesome? And Fred responded, and I did too, that it was these chronic drops in his blood pressure. He would get extreme drops in his low blood pressure, made him feel very sick. He was falling more. And the palliative care doctor says, oh, well, we can do something about that. And one of the things he did was change his medication. And Jennifer was just mentioning that that's something that the palliative care doctor, the team can do. So there were other things that came up in that first meeting, but one thing I really want to share with you was that at one point in that meeting, Fred was feeling emotional too. And he said to our palliative care doctor, and I picture this so clearly, he said, I don't want to live like this. And when Fred would say that to me at home, I would panic and I didn't know how to respond. But the palliative care doctor was so rational and could talk to Fred and connect with him and assure Fred that there was time for those kind of discussions and that he understood Fred's feelings about this and talk to him about what the options were in New York State and that there would be time to make those decisions as they got to know each other and as time went by. So when we left that first meeting, and I can picture it to this very day, we leave the first meeting. Fred was walking with a walker and he comes out and he's walking with the walker and he's standing up straighter and he has a smile on his face and I could see the relief that he felt. It was like, it got lifted off his shoulders. And he it was just such a wonderful first experience. And I could go on about things that happened in the, over the course of the next year about why it was so beneficial both to Fred and to me because of our partnership, because of our love for each other. But one thing I do want to say that goes back to the question you asked Jennifer, and that question was, when should a person request palliative care or be referred to palliative care? And now, because Fred not only had palliative care as outpatient, but then he also had inpatient palliative care when he was dying. And he died in the palliative care unit at Strong Hospital. As I reflect on it, I wish with all my heart that we had had palliative care earlier in his journey, not just that last year because I broke down, because Fred had those worries on his mind right along. And unlike a person who really needs management with pain, although with Parkinson's there is pain, Fred had a lot of pain. Fred's greatest need wasn't managing pain. It was managing the confusion that he felt, managing the worries that were on his mind, the turmoil that he felt, and helping him deal with that progressive, continuous loss of abilities over time. And so I would say, bring palliative care in as early as you can, as soon after diagnosis. Now, I know Doris has had some experience with her spouse and palliative care. I don't know, Doris, you want to add anything to this, please?
Well, I wish we'd found palliative care long before we did. It was a few friends, Mary being one of them, who really encouraged me to get Jeff into a palliative care consult. And like you, the first thing that happened was the MOLST form, and I was more than grateful for that because as a spouse, it's hard to have those conversations, and she was wonderful. She talked to us about what each intervention was and how it might affect him going forward. In particular, my husband a year before had been on a ventilator for 11 days and what that would mean if he were to have to go on a ventilator again. I think that's really the critical piece. She came out, so we had time to think about it. She gave us tons of information. We read about it. We had the opportunity to talk to each other about it. We had permission. That's what it gave us. It gave us permission to talk about it. And he signed it on the next home visit. And just 2 or 3 days later, he had a medical crisis. But that was done, and I'm so grateful that in that really terrible time it was done. When I speak in public, I now speak very strongly for caregivers to get involved with palliative care as soon as possible.
Thank you, Doris. We agree on that.
Yeah.
Mary, back to you.
I can't thank you both enough. And for really a wonderful description of how valuable palliative care has been. And I think, nothing hits home like hearing it from the people who have actually been through it and used it. So thank you both for sharing your experience. Actually, let me ask you both, prior to your own experience, did you have sort of preconceived ideas about what palliative care was or reservations about using it?
I didn't. Fred and I knew nothing about palliative care. I would just say that we were skeptical. We said, what's another specialist going to do to help us? But
Mhm.
boy, did we
Mhm.
learn how helpful it could be. Doris, how about you? Did you have preconceived
Well,
notions?
I've been in the caregiver business for 20 some years, and I had the same misleading thoughts about palliative care and hospice being one and the same. And I was very, very grateful to learn that there was a difference, even though they both came very close at the same time, but.
So if there's any message we can get out there today, it's that they are different and that palliative care is so valuable right from the earliest experience you have with an illness. Jen, if a patient is working with several physicians, several specialists, and they want to work with palliative care as well, how does that work, and who becomes sort of the primary care physician for the or for the patient?
That's a great question. So palliative care specialist, if someone's seeing a palliative care specialist, which is I think what you're referring to, it's a referral like a referral to any other medical specialist, should be covered by insurance. If you can see a cardiologist, you can see a palliative care doctor, so the
Mhm.
insurance on the issue shouldn't be a problem. Typically, for most of the disease course, palliative care is another sort of consultant or like person on the team. I often refer to myself as an extra source of support. And I'm often seeing people in the neuropalliative clinic who are also going to continue to follow with their sort of typical neurologist. And I'm an add-on and an extra support, not a replacement. I'm another collaborator in care. So people will usually still continue to follow with the person who's primarily responsible for, whatever the serious illness was, cancer, lung disease, whatever it would be. Will usually still have their primary care doctor involved, and we're just an extra person. Sometimes, particularly in more advanced phases of disease, and my experience is maybe a little bit specific to neurology, if people are coming to, usually this is when someone is approaching end of life and thinking about paring back non-comfort focused interventions, then palliative care might take over more. For example, I see people with Parkinson's disease who may have decided that they do not want resuscitation, maybe do not want to go to the hospital anymore for issues, and are coming to the point of focusing more on comfort, limiting other medical interventions. Then I will sometimes take over as their primary doctor. And if someone is going to, eventually transition to hospice, just because we have brought it up as something a few times, when someone is transitioning to hospice and they're focusing again purely on comfort, no life prolonging therapies, we really pare down the medications list to everything that just only things that make control symptoms and promote comfort. And that is when the hospice team will take over all their medical care. And they would stop seeing other members of the medical team. But again, that's sort of like a very specific piece of palliative care. Does that make sense?
It does, and it's very helpful to hear about it that way, especially as the consultant and then transitioning more to become the attending or the primary physician. We don't have a lot of people listening today, but I would open it up to those of you who are here to ask any questions. I mean, this is a great opportunity to understand more about palliative care. So if anyone has questions, please, unmute or put them in the chat, either way. But in the meantime, do either of you Bernadette or Jen, have other information you think that I haven't brought up that you think is important for people to know?
You know, the question you asked Jennifer about the collaboration among specialists.
Mhm.
If our palliative care doctor had been meeting with us earlier in the journey, I think that just as Jen explained, your neurologist becomes the nexus for coordinating among specialists. What we found was that Fred's needs and my needs were so great at that point in his life that having easy access to our palliative care doctor was critical, because if something came up at home and I didn't understand what was happening, I got on the phone, called palliative care doctor, and had immediate discussion with him. So and he gave us information that we didn't hear from our neurologist. As an example, he told Fred and me, he said, Fred, if something comes up and you have to go to the hospital for any, whether it's the emergency room or you're in the hospital for some kind of illness or treatment, you're not going to come out at the same level you went into the hospital, that the hospital experience itself is going to put extra strain on you and your Parkinson's symptoms. You might not be able to get back to where you were when you entered into that. And that was very helpful to hear, because as a matter of fact, Fred did have some major hospital stays during that time. And we did see a decrease, but at least we were alerted to
Yes.
that as it might happen.
So that preparation was really helpful to you to at least know what to anticipate.
That's a very good word, and Jen and I have talked about this a lot, this whole concept of anticipatory guidance, so that both the patient and the caregiver have an idea of what to expect, what might happen.
Yeah.
And it doesn't happen to everyone, whatever it might be, and a physician can say that. They can say, it might not happen to you, but it might, and here's what you should know about it. I've
Yeah.
often mentioned to Jen that it wasn't until we met and were and seeing the palliative care doctor that we heard such terms as transfer trauma, that if a person goes from the home to the hospital, there's a trauma there, and you may see some different symptoms, or terminal delirium. I didn't know what that was like until I began to meet with the palliative care doctor. And yet Fred had had a couple of episodes that I blamed on something else. I thought, oh, it must be the prednisone, or it must be this, or it must be that. Didn't understand. So yeah, so
Wow.
there are many benefits to it.
Yes. Yeah, there's much to be said for being prepared for things that, that you may encounter. We do have a question. How do you encourage a friend to consider palliative care for their loved one?
Jen, why don't you start?
This is a good question. I'm a little bit biased because I probably most often have this conversation in a clinical context where I'm a doctor talking to someone. So I probably could speak. So I'm going to be interested to hear what Bernadette and maybe Doris have to say about like a friend to friend sort of convincing. I think that it would start with maybe asking, like, have you heard of palliative care? Because I think, again, there is a lot of this myth busting that has to happen where, if you, I'm going to guess that if you try to tell that for some of your friends, if you said, have you thought about palliative care? They might hear the implication that, you think you or your loved one is dying imminently. You're not necessarily worried about that. So kind of, I would probably start with sort of scoping out like a curious inquiry about what do you know about palliative care, or have you even heard of palliative care? And then share that what you've hopefully learned today, or what you've read about or heard about elsewhere, about how it can be helpful and can be just a really normal part of serious illness care, like across different types of illnesses, right? You know, I know I'm not a cardiologist and I don't work in cardiology, but I know the heart failure program at the University of Rochester now has an embedded palliative care program within it, right? And they're seeing people who are choosing to have heart transplants or other advanced therapies. They're also seeing people who decide not to do those things. And they can help with the decision if people are struggling with, tough medical decisions. So I hope it's becoming more normalized. And I think maybe as a peer and a friend, you can have a role in normalizing it, destigmatizing it. But I'd be interested to hear what Bernadette would say, or I imagine you probably have told people actually that they should think about
Well,
that.
I have told people, I have encouraged people. Two I was successful with, and one I have not yet been successful with, but the two that were successful, two different situations. One, a good friend of mine who was coping with and dealing with a brain cancer, tumors in his brain. And I asked him, have you yet been referred to palliative care? Didn't know anything about it. I told him a little bit about our experience. I really encouraged him to ask, if your oncologist or your surgeon doesn't recommend it, at least ask for a referral, which he did. It turns out that my friend was referred to our colleague at University of Rochester Medical Center, Dr. Kluger. And when my friend said to Dr. Kluger, well, now, it's my friend Bernadette who, encouraged me to go here. And of course, Dr. Kluger said, well, that's the administrator, and she was really pushing you. And it's right. But afterward, my friend said how grateful he was, because he, like Fred, was able to talk to his palliative care doctor about his concerns about dying. How would he die? What would his wife find when he did die? What would it be like? And that was very beneficial for them. Another friend, her husband was already in the ICU. They were dealing with difficult decisions, didn't yet have that most form done. And I said to my friend, please ask for palliative care, which she did. And one of our palliative care doctors came right up and talked to her husband, who was dying, about what his wishes were. And she says she's never forgotten that. So, yeah. Doris, have you talked to people, friends, and how would you encourage them?
It was actually my friends that encouraged me. So, and now when I'm out doing public speaking, I do a whole piece on my experience and my husband's experience in it. And I just try to get the word out there,
Right. Good. Yeah.
Thank you. Thank you all. It seems like we don't have any more questions.
Okay.
Did I miss anything that
Jen,
anyone would like to say?
I was just thinking, and this is maybe partly in response to the last question, but maybe it's a good summary if I haven't said it yet, is, one thing we will sometimes tell physicians who are not sure how to say the phrase palliative care, get nervous about it, and sort of want to refer their patients but aren't sure what language to use to talk about it. One phrase that will sometimes suggest is call it like an extra source of support for a summary, and then we'll see them and we'll suss out like what is needed and what kind of palliative issues there may be. But I think extra source of support is it's just sort of a good summary, and can also be language, like getting back to how do we get people in the door or sort of convince people that this could be helpful for them. I think just extra source of support, extra layer of support is a good frame for healthcare providers looking to make a referral. Can also be maybe a good phrase for community members or social, friends trying to get their friends to palliative care for extra help.
That's great. Now, that, of course, raised another question. Do physicians even talk to their patients or families about palliative care on any kind of a regular basis?
I can take that question. That is highly variable, I think, depending on the medical specialty and depending on what resources are available. So, I'm at the University of Rochester where we have a pretty, I'd say, illustrious history in palliative care, where some big leaders in the field have been on the faculty here. The neuropalliative care clinic specifically was started a few years ago in our department. We probably have one of the largest in the country, and we do get a lot of referrals, and it's very normalized. And specifically for certain neurologic illnesses, it's become quite normal to involve us on a regular and early basis. I don't work in other institutions, so I couldn't really comment on what their practice patterns are, what the resources available at some other medical centers are. I think it is always worth, if you're interested, asking one of your physicians, where would I even go if I wanted palliative care? Because your physician will probably know the local community specific resources and where the referral would need to go.
Can I just say something here? And that is,
Sure.
my experience in the hospital was, oh, your husband doesn't need palliative care, not yet. And it wasn't strong, and it was not in neurology. And to go back to last week's webinar that we did on advocacy in and out of the hospital, I went to patient services who helped me to bridge that gap. And to me, it was just simply a young physician that didn't have the knowledge. And but the resource in the hospital is that patient services, Mary, what's the exact title of that?
Patient and Family Services.
Patient and Family Services. They were able to help me to go around that doctor and get what we really needed. So I just wanted to kind of tie those two together. Not every doctor understands palliative care and hospice, especially the young doctors who are coming in. But there is a resource for you in the hospital if you run into that.
That's great to mention that, Doris. Also, I'm thinking, based on what you said, Jen, that smaller hospitals and rural hospitals may not even have this service. Is that?
Yeah.
Will depend on the hospital. I think with the rise of telemedicine, there may be opportunities if there isn't, for example, a palliative care specialist within the hospital available to see someone in person for, say someone who's in the ICU, like, right, really might be in the hospital for the foreseeable future. There is increasingly interest in building networks of telemedicine consults where, this is happening at the U of R too, where for certain specialties, and I believe palliative care may be one of them, neurology definitely is, there are U of R faculty who are doing essentially telemedicine consults for patients at outlying hospitals to help give specialty support if someone can't be on site all of the time.
Okay, that's another great thing to know. Thank you so much. You both have been a wealth of information, and you too, Doris.
Yeah.
Thank you all for sharing your experiences and your wisdom and your expertise. And thank you again for joining us and sharing this information.
Thank you so much. We appreciate you.
Thanks for
Thank you for the
inviting us. It's
invitation.
my pleasure.
Take care.